to begin with contraception in epilepsy. So there are different forms of contraception. As you all know, there's more the hormonal methods and the non-hormonal methods. So non-hormonal methods are, condoms and diaphragms. And, there's really no contraindication or negative effects of using these of using these non-hormonal methods in women with epilepsy. And now, in terms of hormonal methods, that's where issues get a little bit more complicated because the contraception methods that use hormones can interact with the seizure medications. So basically, there are some seizure medications, and I am going to abbreviate anti-seizure drugs also with ASDs. So it's shorter. But there are some ASDs that can increase how the body gets rid of the contraceptive hormones, thereby it decreases the effectiveness of contraception. And then the other way around, there are, some contraception hormones that can actually increase how the body gets rid of the seizure medication, thereby decreasing the blood level of the seizure medication and potentially increasing seizures. So now in terms of, what are the seizure medications that can, affect the hormonal contraception, here's basically a list of them. These are kind of ordered in terms of older to newer, as well as in terms of, the ones that have greater effect and, down the road, ones that have less effect. So the ones that are more concerning really are the ones on top here. Barbiturates really don't get used very often, so that's not as much of a concern, but and that is one of the oldest seizure medications around. So phenytoin or Dilantin, and basically when I list medications, I'm going to put down the generic names and then also put down the most common brand names or the trade names. So phenytoin, carbamazepine, and basically sort of offshoots of carbamazepine, oxcarb, eslicarb, and then topiramate. So these are probably the ones that are of a little bit more concern because they get used more often and also because they have a greater effect. So a couple of the new ones are, Xcopri and Fycompa. Those still aren't being used as often. And then these down here, lamotrigine certainly gets used a lot. However, it really doesn't have as much of a effect, so it's not of as much concern. And then the felbamate and rufinamide, those really get used very uncommonly. So really, it's the ones on top here that are of a little bit more concern because they have more of an effect and they get used more for seizure medication treatment. Now, which one of the hormonal methods are affected? So the combined oral contraceptive pill is called combined because it has estrogen and progesterone in it. These are also what we call OCPs, oral contraceptive pills, or birth control pills. These are the ones that are most affected by the seizure medications that I just listed. However, some of the others can get affected too, but to a less extent. So for instance, the progesterone only pills, those can also be affected. The hormonal implants like Nexplanon and Implanon, that can also get affected. But like I mentioned, to less extent, Depo-Provera is the shot that gets used every 3 months for contraception. This also is affected to a much less extent. However, if a woman is taking one of those seizure medications that I showed on the list, then in that case, we usually recommend getting the shots done every 8 to 10 weeks as opposed to every 12 weeks, just to help with its efficacy. And then the IUDs, the copper one, as well as the hormonal ones, so the Paragard or the Mirena, those really aren't affected by these seizure medications. So that's usually what we end up recommending more for contraception. Having said that, certainly one of the ones up here could get used. And even for the oral contraceptive pills, if that is the preferred method, then generally we recommend using the pill with the higher dose of estrogen. So not one of these mini pills as they're called. Okay. Then these are the seizure medications that really don't seem to have an interaction with the hormonal contraceptive methods. And these are, often very commonly used as well, especially the ones that are more on top here. The ones on the bottom, less used, but certainly, these are very commonly used, and you don't have to worry about those having an effect. Now, like I mentioned, there's also the other side of things where the oral contraceptive pill in particular can affect certain seizure medications. So lamotrigine is probably the one to consider the most because this is the one that is more commonly used in the US. So basically, the oral contraceptive pills increases the clearance of lamotrigine. So basically, the body is just getting rid of the lamotrigine more when you're on an oral contraceptive pill. Therefore the levels decrease, and then it's possible the medication is not going to be as effective, and then people will have seizures. So I certainly have seen certain women in clinic who mention, I didn't have seizures for years, and then I had one. And then when you talk to them some more, then they'll mention, oh, I was started on a birth control pill. And then it sort of makes sense why they may have had a breakthrough seizure. Now, some of the other methods using estrogen, so the estrogen patch and the NuvaRing can also decrease the lamotrigine level. Typically what I do is, you want to get a level checked before you start on the, pill or the patch or the ring, and then afterwards. And then based on the blood level and the difference between the two, the dose of the lamotrigine can get increased so that the level goes back to where it was before. Now, there are some women, though, where you increase the dose and you increase the dose and you can never get it back up to the level they were on before starting on the birth control method. And in that case, it probably would be better to change to a different contraceptive method, or I guess possibly changing seizure medications. But usually, I think everyone's aware if a seizure medication is working, then it would be best not to make changes to it. So usually, we'll recommend maybe doing a different contraceptive method. And the other thing is if a woman is using the oral contraceptive pill, the birth control pill, and they are on lamotrigine, then there may be changes on the level during their on week and their off week. So basically during their off week, they're taking something that doesn't have any actual hormones in it, or they just don't take it for that week. So it's possible when they're taking the hormones with the pill that their level's lower, and then when they're off not taking it, their level bumps up and gets higher. So sometimes the dose may need to be adjusted for the seizure medication. Valproate or Depakote is another medication that the oral contraceptive pill, the birth control pill, can decrease, but it's not to the same extent as with the lamotrigine. So it tends to not be as much of an issue, but it's probably still a good idea, to get your level checked before and after starting the pill. So next, going from trying not to get pregnant to trying to get pregnant and fertility. So there are, reports about decrease in fertility in women with epilepsy. And there are several proposed reasons for why this might be the case. One being, is it an effect of the seizure medications women are on, and or is it an effect of the epilepsy itself? And in addition to that, there's also sort of, what we call more psychosocial issues, meaning, if somebody has epilepsy and, you guys probably know this better, or especially if, someone has intractable epilepsy, then, they may not feel as free and open to go out in public and meet people and date and stuff like that. So there may be some issues like that related to why there is a decrease in fertility and pregnancy. But the main thing in terms of seizures is, yes, there could certainly be effect of the seizures themselves, as well as what we call seizure markers or the discharges that you may have heard doctors talking about on the EEG. Those things having an effect on reproductive hormones. So if the seizures and these epileptiform discharges are affecting reproductive hormones, then that might lead to issues with fertility. And then in terms of seizure medications, like I mentioned, when I gave the list of the seizure drugs that can affect hormonal contraceptives, those are outside of hormones, but, those medications can certainly affect the hormones going on inside somebody's body that the body is producing on its own. So, because of that, these same seizure medications can have an effect on the reproductive hormones that's made by the woman, and then lead to decrease in fertility. One medication in particular to keep note of is valproate, where this can cause polycystic ovary disease in women, and then that leads to decrease in fertility. And incidentally, it can also affect male fertility by decreasing sperm motility. So anytime a woman is having difficulties, women with epilepsy having difficulties with the fertility, these are sort of things that need to be considered and thought about, and maybe even evaluated for possibility of polycystic ovary disease, especially if somebody's on Depakote or valproate. So, having said all that, there's actually a recent study showing that, there doesn't seem to be a big difference between women with epilepsy and women without in becoming pregnant. So, in this study, they basically looked at about 200 women, 200 women with epilepsy, 200 women without. Both groups were trying to get pregnant. And then they followed the two groups to see how long it took for them to get pregnant. And what the study found was there really wasn't any difference. Both the groups got pregnant at about the same amount of time. So it seemed like there didn't seem to be that much of an effect on fertility. One reason for thinking why this might be the case is that in the past studies where it did show decrease in fertility in women with epilepsy, they were using older seizure medications. So maybe it's these older seizure medications that have a greater effect on fertility, but not so much the newer ones. And I think when I showed the list before, you could see how the medications that affected the hormonal contraceptives, the barbiturate, the Dilantin, the Tegretol, those are actually considered to be the older medications. So it does make sense that maybe that does play a role in this. The other thing is, associated with fertility is there can be this possible increase in miscarriage in women with epilepsy. However, that seems to be really more related to women being on multiple seizure medications as opposed to what we call monotherapy or just the use of one seizure medication. Now, moving on from fertility to pregnancy and actually getting pregnant. So, with pregnancy, there's really sort of, two things. One is the risk of seizures. What does that have with pregnancy? And then the risk of seizure medications during pregnancy. And overall, kind of the general consensus is, hey, women are better off being on seizure medications, controlling seizures, than being off seizure medications and having seizures, because there are certainly risks associated with having seizures during pregnancy. So I've listed, some of the reported risk with seizure. So preterm labor, smaller babies, low birth weight. You can kind of read through the list of things. And as expected, the risk is greater with more severe seizures. So with convulsive seizures, the risk is more, and also the more number of seizures somebody has, the greater the risk. So maybe with just one seizure, that's not much of a risk, but some studies have shown that if you have 6 or more seizures, in particular convulsive seizures during pregnancy, that's where the risk really starts kicking in. Even with the smaller seizures, what we used to call complex partial seizures, so basically a seizure with loss of awareness or impairment of awareness, but without having a convulsion, that has shown to have a decreased fetal heart rate associated with it during the seizure, as well as for several minutes afterwards. How much of an impact this might have on the pregnancy, we can't really say. However, if that happens multiple times during the pregnancy, maybe that is going to have some impact. Now with the smallest type of seizure, I suppose the simple partial seizure or focal seizure without impairment of awareness. As far as we know, there doesn't seem to be any risk associated with those or with the absence seizures. The simple partial seizures or seizures without impairment are also what we often call auras. Now, having said all of this, we don't really have specific numbers in terms of exactly what percent risk it is with seizures. So, I can't say, oh, if you have, 3 convulsive seizures, your risk is 2.3% of having this or that. And part of the reason for that is, we don't stop seizure medications, let women have seizures, and then see what happens at the end. I mean, that's just not an ethical study to do. So because of that, we don't have, hard and fast numbers to say exactly what the risk is of X versus Y. All we know is, yeah, there does seem to be increased risk. And yes, this is sort of a list of some of the reported risks associated with seizures. So in terms of also pregnancy and seizures and seizure medications, the onset of seizures and epilepsy during pregnancy is not that much higher or different really than at any other time. So yes, I have seen, women in clinic who first time got diagnosed with epilepsy, but oftentimes the seizure they had during pregnancy wasn't necessarily their first seizure. They'd actually had some seizures before that just weren't recognized as being seizures. So it's not, higher risk that if somebody's pregnant that, they're going to, have onset of epilepsy at that time. Now, in terms of if you do have epilepsy, what happens with seizures during pregnancy, in majority of cases, it stays the same. It really doesn't change. So in 50 to 70% of women, their seizures are the same before as during pregnancy. Now, there is a smaller group where the seizures can get better, maybe about 10 to 15%. And then a group where seizures can also get worse, about 15 to 20%. But in general, most of the women, their seizures stay the same. And that's the reason why, we want women's seizure control to be really, really good before they get pregnant. So I think doctors often sort of harp on, plan your pregnancy, plan your pregnancy. And this is the reason is, the best seizure control you have during pregnancy, then before pregnancy, then during pregnancy also, you'll have good seizure control. So usually we use the 9-month rule in terms of seizure freedom, meaning if before you got pregnant, you were doing well, not having seizures for 9 months, then during the 9 months of pregnancy, also you're likely going to do well and not have any seizures. So it's really important to get the best seizure control possible on stable doses of medications before getting pregnant. The other thing, that's helpful with is if you're on stable dose of medications, then it's important to get medication levels done before pregnancy so that during pregnancies, if there's changes, we have a comparison to look at and say, oh, this is where we want the levels because at these levels, this person did really well. So that's another thing that it's helpful with. And now looking at the other side of things, what is the risk of seizure medications during pregnancy? So the two things we really consider are risk of malformations and risk of any cognitive deficits. So basically lower IQ, things like that. The best is to use the fewest number of seizure medications at the lowest dose to maintain efficacy at the best seizure control. So there is a dose effect of seizure medications also, meaning if somebody's on a higher dose, that seems to be associated with a higher risk in terms of malformations and cognitive deficits. And also the higher number of medications the higher the risk. In terms of malformations, all that really means is a problem with how the baby forms, right? And malformations occur in the first trimester, since that's when the organs and everything else is forming during that time period. After first trimester, there's really no risk of malformations because things have already formed by that point. Okay. Now, there's really, in terms of malformations, minor malformations or minor anomalies, and major malformations or major anomalies. The minor malformations are not as concerning because they really don't have an impact on a baby's health or welfare. And oftentimes, it's not something that is even recognized unless you really look for it. So basically, structural abnormalities such as maybe the fingers are a little bit shorter, or maybe the ears are a little bit lower set. So these are things that unless you really look for it and measure it, then it may not even be recognized. So the risk of minor malformations is somewhere in that 6 to 20% range. So around 2.5 times higher than the general population. Now, major malformations are, things that are more concerning. These are, structural abnormalities that interfere with function of that organ or that structure, or they may require some major intervention like surgery. So obviously, there's risk of these major malformations occurring in even normal, healthy women, right? So women, normal, healthy women can certainly have a baby with a birth defect, is I think another name that commonly gets used for major malformations. So in the general population, the risk of having a child with a major malformation is about 1 to 3%. So in a woman with epilepsy on a seizure medication, one seizure medication, it doubles that risk to somewhere between 2 to 6%. So even though doubling sounds like a lot, when you look at the actual number, it means that still 95% of women, or actually probably more than 95% of women, will have normal, healthy babies. So that's why we usually tell women, you know, most women with pregnancy will do fine and will have normal, healthy women. It's perfectly fine for you to get pregnant and have a baby. Okay. So the more common malformations are congenital heart disease, cleft lip and palate, where basically the top lip and the hard palate inside the mouth on the top doesn't come together and join the way it should. So there's a cleft, an opening, and then surgery is required to fix it. Or urogenital defects, which is just a problem with the urinary system or the genital system and how it forms. And then neural tube defects, where basically the neural tube is what goes on to form the brain and the spinal cord and its supporting structures. So a neural tube defect is basically a defect in how that forms. Now, folic acid supplementation has been shown to help decrease the incidence of neural tube defects in all women. So we're not just talking about women with the epilepsy, which is why we recommend women take folic acid supplementation. Now, the neural tube actually closes really, really, really early in pregnancy. And sometimes women even don't know they're pregnant at that time. So basically, after conception, the neural tube is closing by, in between like 3 to 4 weeks. So some women may not even realize they're late in getting their period because, it's only been about a week or, a little bit longer. So because the neural tube closes really early and women might not know they're pregnant, at that early time point, we usually recommend that, hey, you know what? All women of childbearing potential should take some folic acid supplementation. We don't know the perfect dose, but the recommendation is somewhere between 1 to 4 milligrams a day. This is just over the counter that you can buy. It does come in a 1 milligram size, so usually that's kind of the easiest to take instead of taking several of the 0.4 milligrams or the 400 micrograms. If there's a family history of neural tube defect, if somebody's on, Depakote or somebody's on Tegretol, carbamazepine, then you should take, the 4 milligrams daily because those are associated with a higher risk of neural tube defects. Um, Otherwise, I usually do still recommend, 4 milligrams a day because there's really no good studies showing that there's anything bad, due to taking a higher dose. So usually I say take 4 milligrams a day. Now, in looking at exactly what is the risk of these major malformations, this is data from the North American Pregnancy Registry, and this is where we get all our data is really from these pregnancy registries. And, there's several throughout the world. This is the one, really through North America. There's ones in Australia, in, Asia, just all over. Now, in terms of the risk of major malformation, according to this registry, they had a control group of just normal healthy women, and the risk of malformation was on average, right, was about 1.6%. So really, you can sort of branch off the seizure medications where we know the risk of into kind of the low risk, moderate risk, and high risk. So in the low risk category is levetiracetam, lamotrigine, oxcarbazepine, gabapentin, zonisamide. With zonisamide, there is some issues with even having kids with a lower birth weight and some acidosis during pregnancy. But overall, the risk of these medications are in the lower end. Then there's the kind of this low risk but category. At least that's the category I put it in, where, yeah, the risks are a little bit higher than what you see over here. And, with the carbamazepine, which is this, like I mentioned, there's the risk of neural tube defects, which is, a lot more concerning than some of the other malformations. And with clonazepam, there's always the concern of the baby having withdrawal symptoms after delivery because the baby's been getting all this clonazepam during pregnancy because the medication obviously is going from the mother directly to the baby through the placenta. So there's the possibility that when that medication in a sense gets stopped after delivery that the baby can have some withdrawal. Then there's medications that we consider more in the moderate risk category, which is topiramate and phenobarbital. And then valproate or Depakote is the high risk one. And that's the one we really like to avoid during pregnancy. Like I mentioned, the more medications, the greater the risk. However, it's not an additive thing. So if one medication's at 2% and another medication's at 2%, if you're taking both of them, it doesn't mean your risk is now 4%. It's still lower than that. So it's not an additive risk. It just sort of adds a bit to it. So maybe with the two medications, it's no longer at 2%, but maybe it's more in that 2 to 3% range. But it doesn't necessarily add up and say, oh, now it's at 4%. Like I mentioned, valproate or Depakote, has a significantly higher risk. And it's even more so if it's Depakote plus another seizure medication, but Depakote kind of overpowers everything, even if it's with another medication. So you really want to avoid Depakote, but there are some women where Depakote really is the only medication that works for their seizures. And in that case, we'll recommend, all right, use the lowest dose possible that's controlling the seizure. And ideally, if it's, 500 milligrams or less, because at that point, like I mentioned, higher the dose, higher the risk, but at the same time, lower the dose, lower the risk. So if a woman is taking only like 400 or 500 milligrams of Depakote, then the Depakote's risk is much lower and is more comparable in that 3% range to some of the other seizure medications that I mentioned that were in the lower risk category. And then finally, there's really, with the newer seizure medications, we don't know. We really don't know what the risk is fully at this point because you essentially need to have hundreds of women taking one particular seizure medication enrolled in the pregnancy registry to get an idea of what the risk is. So if there's just like 20 or 30, we really can't say anything that much about it unless it's a really, really high risk. Then, we'll probably know with even a low number of people. But otherwise, till there's, hundreds of women in this registry on a particular new medication, we're not going to get that data, which then, brings me to, if you're pregnant, enroll in the pregnancy registry. This will just sort of help, others and, for future. Now, in terms of risk of cognitive issues, um, the main thing is with the Depakote, it has been shown to decrease IQ points in children later on in life at age 3 and at age 6. So in this study, they looked at Depakote, Lamictal, Dilantin, and Tegretol, and Depakote was the one that really did show a decrease in IQ points. With the other three medications, there wasn't. And also with higher the dose of Depakote, the lower the IQ point. And obviously, if the mother has a lower IQ, then yeah, the child can also have a lower IQ. However, with Depakote, even if the mother had a normal IQ or a high IQ, with the Depakote, the child tended to still have a lower IQ. And same thing, like I mentioned before, you want to use the lowest dose possible. And also with the Depakote, there was increased risk of autism in this study, possibly maybe with some of the other seizure medications, but that hasn't really been seen in other studies. Um, and then in in another study, maybe topiramate was associated with a lower IQ, but then in another one, it wasn't. So, it's possible that topiramate may have an effect. The other thing, and another reason to take folic acid, is that if a woman was taking folic acid around the time period of conception, their kids had higher IQ. So that's another reason to take it other than neural tube defects. And then in terms of effect of pregnancy on seizure medications as opposed to seizure medications on pregnancy, pregnancy can decrease the level of seizure medications, especially lamotrigine and levetiracetam. And these are the two most commonly used seizure medications in pregnant women. So what we need to do is, monitor levels monthly and then adjust the dose based on what the level was before pregnancy. Or if we don't have that, then maybe early pregnancy when a woman was doing well, not having seizures, then we try and keep the level the same. So if the level drops, usually by more than 30%, then the dose gets increased, because it's the level that's the most important thing, really not the dose in that sense. And this should, as long as the level's the same, the seizure control should be the same and the side effects should be the same. So just by being on a higher dose doesn't mean more side effects. It's actually the level that's more important. As long as the level's the same, then the seizure control and side effects should be the same. And because of this, possibility of seizure medications having an effect on pregnancy, and the risks, one question is always, can the medication be stopped before pregnancy? And this really should be looked at, before somebody gets pregnant, because we're not going to stop seizure medications, if somebody's already pregnant. We're not going to even try and change seizure medications if somebody's pregnant. We just sort of do the best with what they're on, and rarely we'll have to add on a seizure medication, but that's pretty rare. So for instance, like I mentioned, if somebody has only had small seizures, maybe the seizure medication can get stopped during pregnancy. Or if somebody hasn't had any seizures for a few years, maybe we can stop the seizure medication and they don't even need to be on it, except for, people who have what we call the genetic generalized epilepsy. In that case, they probably should stay on a seizure medication. And if it's unclear if somebody has epileptic seizures or not, then probably do hospital monitoring first to figure that out, to see whether or not they need to be on it. And then finally, if somebody's intractable, so if you're having seizures despite medications, then probably look into surgery or some other treatment besides just medications to see if maybe the medications can potentially be stopped. So during labor and delivery, during labor, I guess, let me start off with that. There is an increased risk of what we call toxemia or preeclampsia, and that's basically increased blood pressure, protein in the urine, and swelling of hands and feet. So it's what we call a multi-system disorder where it affects multiple things in the body. Um, so there's a little bit increased risk of that. And women, when they have preeclampsia, they can go on to have eclampsia, which just means they have a seizure or they're in a coma, which is the definition of eclampsia. So there's a slightly higher risk of that happening. So if somebody is really doing well through most of the pregnancy, not having any seizures, and then later on in pregnancy, suddenly they have a seizure, then that's one thing that needs to be considered is, okay, is this necessarily just their epilepsy, or is this preeclampsia or eclampsia leading to the seizure? Seizures during labor and delivery is actually pretty rare. There is a slightly increased risk because of, the sleep deprivation, the pain, the increased stress during labor. But, at most, maybe 1 to 2% of women will have seizures during labor and delivery. So luckily, it's actually pretty uncommon. Um, because of the increased risk with the all these factors, the sleep deprivation, pain, and stress during labor, if the labor is going on for a while, then probably consider an epidural or something to help with the pain, or also consider maybe helping increase the labor more with some medications. C-section, usually only if it's indicated for obstetrical reasons or somebody's having a lot of seizures. There is an increased rate of C-section in women with epilepsy. We don't exactly know why, but that does tend to happen. And then after delivery, if the dose of seizure medications were changed during pregnancy, then we just decrease it back again, pretty much close right after delivery. And obviously during with the newborn, it's there's a lot of stress and there's a lot of sleep deprivation. So it's really important, if possible, to get help from others to help out during that time period. And then monitor for any withdrawal reactions, typically, like I mentioned, with the barbiturates and the benzodiazepines. So need to monitor this, but with the other seizure medications, there really is no withdrawal that tends to happen. It really is more with the barbiturates and the benzodiazepines. Breastfeeding, we recommend breastfeeding, except for with the barbiturates and benzodiazepines, because those are medications that are very sedating. So it can make the newborn really, really sedated. So probably not a good idea with those two medications. But otherwise, we recommend breastfeeding. You watch for, the common things that you would watch for anyway, whether, on a seizure medication or not, is the baby really sleepy, so not waking up to feed, or very irritable, or there's any growth issues and weight loss. So those things, you monitor during breastfeeding. But overall, there's a lot of studies showing a lot of really good benefits from breastfeeding, but there are no studies, zero studies, showing anything negative associated with breastfeeding. There are several studies showing that with breastfeeding, there is no negative impact. So that's why, because of that, we recommend breastfeeding. And also, breastfeeding has been associated with higher IQ, especially in women who took Depakote during pregnancy, meaning, if the women took Depakote during pregnancy, the kids tended to have lower IQ. However, if the mother breastfed, then the kids' IQ was actually higher than the kids whose mothers didn't breastfeed and was taking Depakote during pregnancy. The increase in IQ was about 12 points actually with breastfeeding with the Depakote children. So that's actually pretty significant. So overall, if anything, maybe some benefits of breastfeeding on seizure medication, but no studies showing anything bad. So if you can breastfeed, usually we do recommend that. And then genetics. So what's the chance that, hey, your child's going to have epilepsy? So yes, there's increased risk of epilepsy in children of people with epilepsy, whether mother or father. However, it's higher with what we call the idiopathic generalized epilepsy. So it's about 6 to 7 times greater risk compared to general population. However, even though that sounds like a lot, it's still less than 10% overall. Okay. And the children can have the same type of, generalized epilepsy, or they can actually also have focal epilepsy, so a different type of epilepsy syndrome. With focal epilepsy, the risk is a little bit less, so maybe 2 to 3 times greater, more if the mother has it than the father. So with father, it's not, there doesn't seem to be as much of a risk, or maybe it's about the same as with the general population for the children. And there are obviously some more genetically based focal epilepsies. This is like autosomal dominant nocturnal frontal lobe epilepsy. And in this specific group, there's a greater risk that children will have epilepsy. So if there's a lot of family history of people with epilepsy, then this is something that can be looked at just to see if maybe there's that family genetics involved. And there's an increased risk of what we call febrile seizures, or seizures associated with fevers in children. This only happens around from 5 months to 5 years of age. So it's something to sort of watch out for. And if the child does have a fever, so if your son or daughter is having a fever, they're in that 5 months to 5 years range, maybe be a little bit more proactive in treating the seizures, instead of just kind of letting it go. So catamenial epilepsy is basically increase in seizures related to a woman's menstrual cycle. This does not happen in all women, even though a lot of women report it. When you actually do studies, it's maybe about 30% of women have actual catamenial epilepsy. And there tends to be three patterns. So perimenstrual, meaning there's an increase in seizures around the time of menses. So right before the period, like a couple of days before, and then maybe into a few days during period, and maybe up to even a few days after. So that's the perimenstrual, and that's the one that's the most common. Then periovulation, meaning around the time of ovulation, which is about 2 weeks out from the first day of the period. And then second half of the menstrual cycle for some women who are actually not having ovulation during that cycle. The reason for this is not fully known. What we do know is, and what we think is involved in this, is that estrogen tends to make seizures worse. Progesterone tends to help seizures. Therefore, during the time period of normal menstrual cycle, there are times where the estrogen is high and or the progesterone is low, so that seizures tend to occur more during these time periods. So for instance, around ovulation, there's this estrogen surge. So estrogen really goes up high and the progesterone is low. And then around the time period of menses, or women's period, progesterone is really low. And then if somebody's not having ovulation, they have low progesterone throughout the second half of their menstrual cycle. So women who have catamenial epilepsy actually tend to have less seizures during pregnancy, because the hormone isn't fluctuating up and down like it normally is during their menstrual cycles. And there are certain medications that can be used to help with catamenial epilepsy. Now finally, and this is my last slide, is menopause. So with menopause, women's seizures can increase and get worse. So maybe about 40% of women, their seizures get worse, 25% decrease. Rest, there's really no change and it stays about the same. The reason, for, or at least the possible reason for, why there might be this change is related to hormones again, because that's what's going on with the menopause, is there's a change in hormones. So maybe, there's more fluctuating hormone levels. So things are kind of going up and down and more out of whack. So maybe that's why there's a bit more of an increase. Now, in terms of hormone replacement therapy during menopause, this is actually associated with an increase in seizures. And that's probably because the hormone replacement therapy includes estrogen. And like I talked about before, estrogen tends to make seizures worse. So, with hormone replacement therapy, seizures can actually get worse, especially in women who have, history of catamenial epilepsy. And then after a woman is totally done with menopause, then that's when the seizures tend to get better. If anything, it's more kind of during that menopausal time period that the seizures tend to get worse. Okay, so that's it for me. Thank you.